A lot of the factors relate to presence of tissue, availability of tissue, presence of adequate tissue. So tissue can be available, but it's not adequate enough to allow testing. Logistical, and that's very important. So let's say a patient comes to a clinic at the university, has had their biopsy in their community hospital. By the time they see the oncologist, and there's a treatment plan to be decided, the tissue is in a different place. And by the time you get the tissue and you get it tested, that's about 4 weeks, sometimes 6 weeks. So logistically, it is very challenging, and the patients will not wait 4 to 6 weeks before they start the treatment, especially that there is no data that suggests that an EGFR inhibitor is superior to a VEGF inhibitor at that time. And so there is no need, urgent need, to wait for the results of the test. So that's one. Two, although most university and large practices have their own testing, and it still takes about a couple of weeks, which is reasonable, to do the testing. A lot of the community practices actually send out those to outside vendors, and these take about 4 weeks to get those. So it's logistical, timing, presence of tissue, presence of enough tissue to test for RAS. And those limit the percent of oncologists who actually end up doing this test and not reach that 100% bar that I think we should thrive for.